A very good afternoon to one and all. It takes immense pleasure for me to introduce the speaker for today's session of classroom series under the Agenesis of Neurocritical Care Society of India. So Deepti ma'am is my senior from NIMHANS and alumnus of NIMHANS. So she's done her fellowship in neurocritical care and neuroanesthesia from NIMHANS, and she's going to present on the topic status epilepticus. I would like to introduce our moderator for today, Shalini ma'am, who is the head of neurocritical care at CMC Vellore. Welcome ma'am. So over to you, Deepti ma'am.
Thank you, Dr. Matangi. A very good evening to all. So let's jump straight into the topic, status epilepticus. It's a vast topic. I have tried to touch upon all aspects. It's a dry topic, so I'm trying to make it as interesting as possible. Little bit of theory, little bit of clinical aspects. So I will start off with the definition. So this definition is by the Neurocritical Care Society, which came out in 2012. Update has come in 2015, the Brophy et al. Guidelines. This defines status epilepticus as 5 minutes or more of continuous clinical or electrographic seizure activity or a recurrent seizure activity without any recovery or returning to the baseline. This definition was adopted, which changed from the 30-minute conventional timing, because most clinical and electrographic seizures last less than 5 minutes, and seizures that last longer do not stop spontaneously. Also, animal data suggests that permanent neuronal injury and pharmacoresistance, all of this occurs before the traditional definition of 30 minutes of continuous seizures. The classification given by the Neurocritical Care Society is the convulsive, non-convulsive, and refractory status epilepticus. Now, convulsions associated with the rhythmic jerking of the extremities, with generalized tonic-clonic movements, it are associated with mental status impairment and may have a functional neurological, focal neurological deficits in the postictal period. This all come under the generalized convulsive status epilepticus. The non-convulsive status epilepticus, here the seizure activity, as we know, is seen on the EEG without any clinical findings. Two phenotypes have been distinctly described in this guidelines. One is the wandering confused. Here the patient has actually good GC, presence with a good prognosis. And the other one is a subtle status. Here the patient is acutely ill with severely impaired mental status. The semiology of the non-convulsive status, it can present as negative symptoms as well as positive symptoms. So negative symptoms could be aphasia, mutism, amnesia, catatonia, coma, confusion, staring picture. And positive symptoms can be agitation, automatisms, blinking, delirium, delusions, sometimes twitching, laughter also, psychosis, tremulousness, etc. Refractory status epilepticus has been defined as when the patients do not respond to the standard treatment regimens for the status epilepticus. They will continue to experience either clinical or electrographic seizures despite receiving adequate dosages of the initial first line and second line therapy. They are the refractory ones. Now, the next step is the super refractory status epilepticus. Here, the patient experiences a continuous seizure for greater than 24 hours despite even the IV anesthetic agent. Now, refractory and super refractory are definitely a medical emergency here, because the mortality rate almost exceeds to about 40 to 50%, and there's significant morbidity. We can say only like 1/3 of the patients will return to the pre-morbid state. Talking about the etiology, the various etiology across many studies, the maximum weightage is for the cerebrovascular conditions. Then there is degenerative metabolic. Lower down we have trauma, tumors, etc. When we divide it into acute and chronic processes, acutely there can be metabolic disturbances with electrolyte abnormalities. Hypoglycemia is a very common and important cause, which should not be neglected. Then renal failure, there's infection, stroke, trauma, drug toxicity, withdrawal from certain drugs or non-compliance of the anti-epileptic agents, hypertensive encephalopathy, and autoimmune conditions. Chronic conditions can involve pre-existing epilepsy and tumors. Briefly, I'll talk about the pathophysiology involving status epilepticus. In convulsive status, the homeostatic mechanisms actually initially for a period of about 30 minutes, they compensate for the extreme metabolic demands of the body because of the seizing brain and the contracting muscles. There is tachycardia, hypertension, dilatation of the cerebral blood vessels, increasing in the blood flow. There is initial hyperglycemia because of the high demand for the energy. However, later on, it goes to a decompensated state, which leads to wherein there is anaerobic metabolism with rising lactate levels, acidosis, cardiac arrhythmias, etc. The repetitive muscle contraction can lead to hyperthermia, rhabdomyolysis, and electrolyte imbalance, eventually leading to a neuronal injury and cell death. A very important feature of status epilepticus is that it causes a blood-brain barrier impairment, which will activate the cells, the neurons, the astrocytes, microglial cells, the macrophages, the neutrophils in the brain. This activation will lead to a surge in the pro-inflammatory mediators. Now, these pro-inflammatory mediators will lead to neuroinflammation, which will increase the frequency, the duration of the seizures, as well as it will reduce the seizure threshold. So basically, it leads to a vicious cycle. The seizures leading to impairment and the inflammatory mediators, which again leads to further seizures. Now, as clinicians, for us, very important to know is why does the status epilepticus, which is a moderately treatable condition, become super refractory? When it becomes super refractory, it is refractory to all the anesthetic agents, all the modalities that are available. So it's very important for us to know why that happens. So it is seen that treatment, when it is offered initially, about 80% response is seen when the treatment is started within about 30 minutes of the when the seizure onset. But this effectiveness comes down to say even 30%, 40% when the patient's first line therapy starts after he has seized for maybe 1 or 2 hours. So what really happens at a cellular level is what we need to know. So in this picture, you can see this is the synapse. You can see GABA receptors are present, glutamate receptors are present. So after a continued status, what really happens is there is changes in the protein phosphorylation, there's changes in neurotransmitter release and ion channel changes. So we can see here, this lysosome is actually eating up all the GABA receptors. So that is called as internalization, or there is a downregulation of the GABA receptor. At the same time, the endosomes are releasing more and more glutamate receptors. So we can see here, there's upregulation of the glutamate receptors. This process is called as receptor trafficking. So because of this, irrespective of how much neurotransmitter is present, because of the lack of the GABA receptors and increased glutamate receptors, what really happens is there is pharmacoresistance to the GABA receptor modulators, which are our first line agents, even our anesthetic agents, they stop acting. At the same time, there is pharmacosensitivity to the NMDA antagonists, which acted the glutamate receptor. So that's where the role of ketamine, etc., comes in, which I'll be discussing later. I will skip this slide. Coming to the pharmacotherapy in brief, for status, we have the sodium channel blockers. For example, afinitor, lacosamide, oxcarbamazepine, carbamazepine, which keep the sodium channel in an inactivated state and prevent them from going into an active state. We have the calcium channel blockers, the pregabalin, gabapentin. They prevent calcium influx into the cell, which will result in depolarization and the action potential and the seizure propagation. Then we have the GABA agonists, which are the first line agents, benzodiazepines, and also the other anesthetic agents, barbiturates, propofol. They act at the chloride channel. They facilitate the chloride entry and thus hyperpolarization. There is GABA transaminase inhibitor, vigabatrin. This opens up the central chloride ion channel and thus leads to again hyperpolarization and reduces the cell excitability. Tiagabin is not mentioned here. That's GABA reuptake inhibitor. Coming to SV2A modulators, these are most commonly used, our levetiracetam and most recently the brivaracetam. Now these are involved in controlling the exocytosis of the neurotransmitter containing vesicles. And brivaracetam is it has more affinity to the SV2A in the brain. So this is a more recent agent. Then we have the glutamate receptors, the NMDA receptor inhibitor, which is ketamine, which will prevent the acting of the excitatory neurotransmitter glutamate, and perampanel, which acts as the AMPA. It is AMPA inhibitor. This is required for the propagation, the epileptic synchronization, and the spread of epileptic discharges. Now, coming to the management proper of the status epilepticus, the traditional method, as we all know, it's the first line, second line, third line, and fourth line. But the current guidelines have basically it's a change of nomenclature, and the rest of the therapy remains the same. They have named it as emergent initial therapy, urgent control therapy, refractory therapy, and maintenance therapy. So, emergent initial therapy. Is as usual, the benzodiazepines is obviously the first line agents. Preferred is lorazepam or midazolam. If we do not have IV access, then we can go in for IM midazolam. It is as effective as IV lorazepam. Then, of course, even the phenytoin, fosphenytoin, phenobarbital, valproate, and levetiracetam also come under the initial therapy, in which, so among these, lorazepam and bedazolam are the ones which have a class 1 evidence. Some salient features we need to know about this is that the most common complication encountered is respiratory depression and hypotension with these agents, and these drugs will cause metabolite formation, propylene glycol, which is known to cause lactic acidosis and thrombophlebitis, so that has to be kept in mind. And phenytoin, fosphenytoin, when it is given as infusion, it can result in arrhythmia, so cardiovascular monitoring is required. And coming to valproate, it can cause hepatotoxicity and hyperammonemia. Now, next step, if the patient is not responding to the first dose or a second dose of benzodiazepine, is to go in for an urgent control therapy. The drugs are almost the same, which is the second line agents, the valproate, phenytoin, continuous infusion of midas, or phenobarbital and levetiracetam. Now, there is no timeline that is given in the guidelines, but it is basically what clinically your judgment has to take place over there. So 5 minutes is usually the time we give for the first line agent, another second dose of benzodiazepine for another 5 minutes, and then go in for the second line agent. If the urgent control therapy is successful, the patient is responding to the first line, then immediately we have to go in for the maintenance therapy, that is to bring up the peak plasma levels of the second line agent. But if they do not respond, then we have to go in for the refractive therapy. Here, it is basically the use of anesthetic agents. There is continuous infusion of midas, propofol, thiopentone. Along with that, you have to go for repeated boluses at regular intervals of one of these agents, one or more agents actually, valproate, levetiracetam, phenytoin, lacosamide, all of these agents. So the goal here is to monitor EEG and aim for a burst suppression or isoelectric EEG, maintain these infusions for a period of around, say, 24 hours, sometimes even 48 hours, and then gradually withdraw, and give other supportive measures, which can be mechanical ventilation, vasopressor support, hemodynamic management, and other supportive management. I did not mention the dosages of the agents. So the dosage is very, very important, because underdosing is more dangerous than not dosing at all in treating status epilepticus. So right dosages have to be given. For the refractory status epilepticus, infusion wise, midas up to 2 mg per kg per hour, propofol say up to 200 mcg per kg per minute, and thiopentone up to 5 mg per kg per hour is a recommendation. Now, the common adverse effects with all of these are respiratory depression and hypotension, cardiac depression, and all the complications you see with critical care in critical illnesses. Um, Sorry. Now, some other salient side effects we see with propofol is a propofol infusion syndrome, which, as we all know, happens with very high doses for extended periods of time. So that's greater than 48 hours, and in which there is an accumulation of lactates, there's metabolic acidosis, rhabdomyolysis, cardiac depression, there's bradycardia, renal failure, hyperkalemia, and all that. So monitoring of the lactates and the acidosis and all is important there. Now, thiopentone. So, as we know, that barbiturate coma is quite the gold standard for managing refractory status epilepticus. It is known to be neuroprotective. It will lower the core temperatures, which is, of course, beneficial in status. But at the same time, there are some side effects. It causes severe hypotension, sometimes refractory to vasopressors, and multiple and high dose of vasopressors are needed. It is known to depress the immunity, and so the patient is very much prone to infections, ventilator-associated pneumonia, and more importantly, it tends to accumulate. So the half-life keeps on increasing as the duration of infusion increases, and after stopping, there are sometimes you have to wait for 24 hours, 48 hours, sometimes couple of days for the effect of it to wear off. So that has to be kept in mind. Again, the duration, the dosage intensity is not mentioned clearly in the guidelines. It is clinically, we have to, what norm that is followed is we give the infusions for 24 to 48 hours and then slowly taper. This, of course, is along with the other anti-epileptic agents, the line 1 and line 2 anti-epileptic agents. Slowly taper these infusions and then watch for the response. That's basically, it's a trial and error method which we usually follow. We are actually buying time to reduce the neuroinflammation, to reduce that receptor trafficking that was happening, and for the decompensatory mechanisms to stop. And waiting for the neurons to return to its original physiological state, and then we have to taper these agents. Now, along with all these first line, second line therapies that start right from the ER, the diagnostic workup starts hand in hand. So, these are the diagnostic workup that has to be done. The glucose, a head CT, very important for the diagnosis of the cause for the seizures. Other tests, the basic metabolic panel, all the electrolytes that needs correction. Continuous EEG monitoring is very, very important. If and when available, as early as possible, it has to be started in an intensive care setup. And again, based on the presentation and MRI, if suspected infection, go for an LP if there are no other contraindications for that. Toxicology panel is very important to rule out what are the toxins which are causing the seizures. And of course, other lab tests, coagulation profile, etc. Rule out inborn error of metabolism, other rare causes of epilepsy. So just to sum up, we start off with an IV benzodiazepine, other second line drug in established seizure. Then we go on to infusions, intravenous midas or propofol infusion. Late refractory, we go on to thiopentone. And if still the seizures are persisting, then we have to go on for other modalities, other anesthetic agents, other approaches and drugs, which I will come back to later. Uh, just a word on this newer agent, neuroactive steroids. Alpregnol has been used to stop the convulsive seizure in animal models. However, when they did the study in humans, clinical trial was done with brexanolone. It's a proprietary aqueous formulation of alpregnol. The phase 3 in the status trial, it did not meet the primary endpoint, and they saw a similar result between the brexanolone and placebo. Now, before going on to the alternative therapy, I will just talk about the continuous EEG in status epilepticus. Now, the cumulative duration of status itself affects the mortality, and the high seizure burden is associated with the worse neurological outcome. So, ideal is to initiate the continuous EEG monitoring within 1 hour of the suspected status epilepticus, and it is suggested to continue the monitoring for 24 hours, 48 hours, or even better, as long as you're treating the patient in the intensive care unit, infusions are going on, it's better to monitor the continuous EEG. What are the indications? Status epilepticus without return to baseline for greater than 10 minutes, converted from convulsive to non-convulsive. So obviously monitoring is very important there. In cases of coma, including post-cardiac arrest, intracranial hemorrhage, suspected non-convulsive seizures in patient with altered mental status, subtle seizures, and very important during pharmacological paralysis. We will not be able to appreciate the clinical seizures here. Now, and then treatment endpoints based on the continuous EEG is for the cessation of the non-convulsive seizures, if there is diffuse beta activity, burst suppression 8 to 20-second intervals is seen, and then complete suppression on an isoelectric EEG. That will be the endpoint. Now, just a word about the burst suppression. This is a simple picture showing the burst and the suppression pattern on this one entropy monitor. So burst suppression is an intermittent high power broad spectrum oscillation alternating with the isoelectric. So basically you have the bursts here and the isoelectric EEG here. So burst suppression ratio is the duration of EEG in suppressed phase, this suppressed phase to the entire time duration. A sustained burst suppression pattern defined as anything above 80 to 90% of burst suppression ratio, which we're supposed to maintain during the continuous infusions of our anesthetic agents. Now, for the continuous EEG monitoring, a 32-channel EEG can be placed. This is not very practical to be used in an ICU setup since the patient keeps moving and we may not be having this kind of an access to the patient's scalp. So it's based on 10-20 system to monitor the EEG. With every 10-20 percentage of the from the nasum to inion is taken and the leads are placed. More simpler would be probably use a 4-channel or 8-channel EEG, which can be placed in the area of interest, and then continuous monitoring can be done. These are the varied morphologies: sharp spike, high voltage spike activity seen here, delta brush pattern, poly spike kind of activity here, spike in wave pattern. Here, as you can see, there are spikes happening here, and at this point, there is cessation of the seizure, and then followed by an isoelectric EEG. I will also share one video. This is seizure activity where high frequency waves with spikes are seen. As you can see here, high voltage activity spikes are seen here. After which, after some time, we've given a propofol bolus. So after propofol bolus, we saw a slowing of waves. You can see in a few seconds. The sharp spikes have stopped. It is much slower. Okay. Now, finally, coming to in a superrefractory or refractory status epilepticus, there are multiple alternative therapies prescribed. They are pharmacological and non-pharmacological. Uh, Starting with pharmacological, there is ketamine, steroids, inhalation anesthetics, IVIG, plasma exchange. In non-pharmacological, there is invasive and non-invasive neurostimulation, modulation techniques, ketogenic diet, hypothermia, ECT, and surgical management. Sorry. Um, So these are all novel interventions based on anecdotal case reports, and we don't have any randomized studies or any randomized controlled studies for this. As you can see here, only for anesthetic agents like propofol and thiopentone, there are RCTs, and rest of all are based on case series or simple case reports. Now, starting off with ketamine, ketamine, as we know, it's an NMDA antagonist. Sorry. It's an NMDA antagonist and it inhibits the glutaminergic transmission. Various studies have mentioned, various case reports have mentioned dosages of 1 to 4 mg per kg per hour. And they have given that for 2 to 4 days along with the midazolam infusion. And after stopping ketamine, they have seen a 60 to 90% decrease, patients achieve 50% decrease in seizure burden, and 65% patients had complete seizure cessation. Now it's a sympathomimetic agent, so we definitely don't have to worry about hypotension and cardiac depression with this. Also, no effect on ICP was seen even on prolonged and high dosages. Next will be magnesium. This is, of course, very much useful in cases of eclampsia, which present with seizures, and cases with acute acquired hypomagnesemia and acute intermittent porphyria. Now, corticosteroids. The role of corticosteroids come in when the epilepsy is of inflammatory origin or autoimmune origin. It can be used as an adjunct, but not as a primary therapy, of course. Then next we have IVIG. Again, in immune-mediated inflammatory or febrile seizures, encouraging results have been seen, especially in West syndrome and Lennox-Gastaut syndrome. There are multiple case reports. Also, this there have been studies which showed that antibodies are developed against neural elements in superrefractory seizures. For example, antibodies against NMDA receptors, antibodies against voltage-gated potassium channel that have been seen. And as we saw earlier, the neuroinflammation, which causes the continuous vicious cycle of seizure and the propagation of the seizure. So that's where the role of steroids, your IVIG, even plasma exchange, all of that come in. Now coming to inhaled anesthetics. So isoflurane has been used, and also desflurane in certain case reports that they have mentioned. The mechanism of action is not well understood. It is likely due to the potentiation of the inhibitory postsynaptic GABA receptor. And also the effect on thalamocortical pathways have been implicated. As we all know, isoflurane has a favorable effect on cerebral metabolism. The advantages are it has a rapid onset of action, and we're able to titrate the dose. But the cons is need for a setting up of a workstation in ICU, and also it has seen that recurrence of seizures was very high after discontinuation, and it has seen that there is a significant increase in plasma organic fluoride was reported in patients receiving isoflurane for prolonged periods. Other side effects, of course, are associated with any critical illness, atelectasis, VAP, and infection, sepsis, DVT, decubitatus ulcers, they're all seen with in these conditions. Another deadly side effect of inhalation anesthetics, as we all know, is precipitation of malignant hyperthermia or something like that, which we actually saw in one of the patient in which we administered isoflurane in a case of refractory status epilepticus. It was not, she developed hyperthermia about temperature of reaching 106, 107 degrees. But unfortunately, we were able to taper it quickly, and having such a high mortality and this lack of availability of dantrolene, we could actually salvage this patient and discharge her from the ICU. Now, coming to the non-pharmacological methods for alternative therapies for status epilepticus, we have the neuromodulation techniques. First one is the vagal nerve stimulation. This is based on the principle of response of the vagal nerve stimulation to tachycardia. So basically, heart rate changes precede electrographic or clinical changes during the seizure. So what it contains is it consists of a generator which is implanted in the subclavicular region, connected by a lead to electrodes which are placed around the vagus nerve. This is like a pacemaker basically, and from here the stimulation is carried up to the brain, and it works on modulating the neurotransmitter release. Okay, so side effects, of course, are cough, hoarseness, dysphagia, and voice alteration because the electrodes are placed right around the vagus nerve. Uh, the battery life comes to around 5 to 10 years, and the effect is, of course, seen mainly in the long term. It's not an immediate effect, so it can be used in adjunctive therapy. The next method is the responsive neurostimulation. Here, a neurostimulator is placed on is implanted, and along with cortical strips or a depth lead. Now, this delivers stimulation into the basically this neuro stimulator is programmed based on the ictal patterns of the patient. The EEG is studied and a software is prepared, which is and the stimulation is pre- which is given to the patient is based on the personalized patient EEG pattern. So it triggers a train of up to 5 bursts of electrical stimulation, zero point 0.5 to 12 milliamperes current for 100 to 200 milliseconds. It has a long-term neuromodulatory effect, and of course, since it is an implanted um, electrode, there is always a chance of infection, hemorrhage, and lead failure, etc. Now, DBS, deep brain stimulation, as we all know, this consists again, same thing, a generator that is implanted here, and the electrodes which is implanted in the deep brain, that is in the thalamic subthalamic nuclei. Um, Most commonly, it is placed in the antithalamic nucleus and centromedian thalamic nucleus for epilepsy. This delivers low frequency stimulation as well as high. The stimulation either disrupts the seizure propagation or raises overall seizure threshold. The low frequency stimulation restores normal neuronal electrical activity, whereas the high frequency stimulation disrupts the propagation of synchronous neural activity. A recent trial showed 41, 56, and 68% median seizure frequency reduction at 1, 2, and 3 years of DBS. Basically, again, it's a long-term effect, not an immediate. We will not see an immediate abolition of seizure with this. Electroconvulsive therapy, this is not really recommended routinely. Just for completion's sake, I'm putting it out here. The mechanism of ECT is related to the modulation of GABAergic transmission. The GABA concentration has been demonstrated to be increased after ECT. It also prolongs the refractory period after a seizure. But very high intensity stimulation is required to achieve the anti-seizure effect as compared to the intensity that is used for common conditions such as depression, which is treated with ECT. And again, another con is that the seizure reduction reported is only 21 to 57%, and for a very short period of time, 2 weeks to 3 months. So we need to keep on repeating the ECT, which is not really amenable to therapy. Coming to the next one, these are non-invasive methods. Transcranial magnetic stimulation. This consists of a TMS coil. Basically, it's a figure of 8 or a round coil is placed, and electric current is passed through this coil, which results in the formation of a magnetic field. Once this magnetic flux passed into the neural tissue, which is the secondary coil, from here a secondary electric field is generated, and which result in persistent depolarization of the neural elements, and that depolarization will reduce the seizure propagation. So the depth, since it is placed here outside and it's a magnetic flux which flows in, the depth of stimulation is only 2 to 4 centimeter below the cortical surface. Response rate is about 50%, and the durability is very limited because recurrence of seizures is known to occur about within 72 hours, even up to 4 months in 73% of initial responders. So not really recommended. Um, so more recently, the transcranial current stimulation has come up. This is a more safer, less expensive variety, and it's a less bulky machinery. So this consists of a battery-powered generator, which is connected to cathode and an anode. The cathode is placed on the epileptogenic focus, and the circuit is completed by the anode. 2 milliampere current is direct current is the stimulation given, and this is known to reduce the interictal epileptic discharges up to around 50 to 64%. More recently, smaller multi-channel transcranial direct current stimulation is being used, which allows targeting of multiple foci and which reaches deeper regions. Um, Another modality in this is the high definition transcranial direct current stimulation. Here, there are multiple anodes placed around one cathode, and that is integrated with EEG, and real time seizure monitoring is being done. Same 2 milliampere direct current is given, and here they have seen the spike rate reduction by around 50% during the stimulation, and there is a delayed cumulative effect. As with all the neuromodulatory methods, the reduction happens after 4 to 5 weeks of the therapy. Now, coming to the other modalities, ketogenic diet, which is a high-fat, low-carbohydrate, adequate protein diet. This is designed to mimic the fasting state, and it induces the ketone body production through fat metabolism. And during this therapy, ketogenic diet therapy, we also have to give other supplements like multivitamins, vitamin D, and calcium supplements. Side effects seen are hypoglycemia, hyperlipidemia, hyponatremia, and weight loss. So there are only a few case reports for ketogenic diet. First one published in 2014. They have given a ketogenic formula of 4:1 ketogenic diet ratio, that is the fat to carbohydrate / protein ratio. They saw 9 out of 10 patients achieve the ketosis and eventually resolution of status epilepticus. 7 patients had clinical and electrographic seizure resolution within 1 week of diet initiation. But of course, most of the patients always receive adjunctive treatment with multiple anti-epileptic surgical interventions, steroids, IVIG, etc., etc., etc. So we cannot really uh, know what is the cause for the reduction in the seizure. Another case report shows much better results, Sarvanka et al., where 14 out of 15 patients completed the treatment and the superrefractive status resolved in 11 patients. So a very high success rate of 79% they saw. Now coming to epileptic surgery. Now epilepsy surgery offers a chance for seizure remission in about 30 to 40% of patients, which is quite promising. And so a patient with refractory focal epilepsy and a normal structural MRI is the ideal candidate for epilepsy surgery. And ideally, so we should have a single epidepilogenic focus that is not in the eloquent cortex. So most common location, seizure location, which is amenable to surgical cure is the medial temporal lobe. So initially, the pre-surgical evaluation is done to determine the epileptogenic zone and its relationship to the eloquent areas of the brain. This is very important. How to identify the seizure focus? We have the non-invasive techniques, ictal and interictal EEG, high-resolution MR with epilepsy protocol is done, neurocognitive testing is done, video EEG telemetry, PET scan, which will show a hypometabolism on the seizure focus, and SPECT, which shows hyperperfusion ictally and hypoperfusion interictally. Then functional MRI. Then there is magnetoencephalography, which is basically a functional mapping. Then there are other invasive techniques where intracranial EEG is done with depth or subdural electrodes. So here, these are the depth electrodes, as we can see here, placed, and these are the subdural electrodes. These are all done intraoperatively after a craniotomy. And as anesthetists, I think what we need to know during this intracranial EEG recording is that the maintenance of anesthesia has to be tailored, as to be not using much of inhalation agent, or for maintenance not using of propofol and other anesthetic agents, which will mask the seizure focus. It will be difficult to identify the seizure focus. Ideally, using high dose of opioids or using a dexmedetomidine infusion is preferred during this at the time of the mapping. Now, before epilepsy surgery, this WADA test is popular, that has to be done. Initially described by June WADA, this was a short-acting barbiturate amobarbitol, which is injected into the ICA through a femoral puncture, which results in a unilateral hemispheric anesthesia for approximately 10 minutes, during which a memory or language testing is done. And after recovery, again the recall of the memory items is tested. Then this test is repeated on the opposite side. The amobarbitol is not really available easily now, so even propofol, ritomidate is a viable alternative. So what is the importance of this test is that patient with a unilateral temporal lobe epilepsy will have a significant memory asymmetry, as the epileptogenic hippocampus is already dysfunctional. So we have the demonstration of the intact function of the contralateral hippocampus is very important prior to the temporal lobectomy, so that to prevent severe post-operative amnestic syndrome. Now, describing the epilepsy surgeries per se, firstly, there is a focal resection, which is a temporal lobe resection, and the extratemporal lobe resection, um, which is used for mainly done for medial temporal lobe epilepsy. Then there is lesionectomy, which is done in case of neoplasms or in case of any structural brain region malformations of the cortical development or vascular malformations. Then there is hemispherotomy or hemispherectomy. Basically, it is disconnection of the one side of the cortex to the other. Anatomical obviously means removal of the entire hemisphere, which is not usually done nowadays. They do a functional hemispherectomy, wherein only the temporal and the central cortex is removed, and the occipital and the frontal regions are not removed in the entirety. And more recently, the other method of doing it is they work from within the ventricle and cause a and make a disconnection between the both the hemispheres. Then there is the multiple subpile transections. This is done mainly when the eloquent cortex is involved, where the horizontal connections disruption is done, and this is done so that the ascending and descending tracts are left untouched and they are not um, um, affected during the surgery. Then there is laser interstitial thermal therapy, corpus callosotomy, where there is a transection of corpus callosum is done. Uh, then there is stereotactic radiosurgery using the gamma knife surgery. Now, the postoperative seizure remission rate seen with epilepsy surgery is about 52% at 5 years and 47% at 10 years, which is quite a good outcome. But of course, it is again a long term outcome, not an immediate effect. Now, finally, coming to I'm just listed drug trials involving status epilepticus. When it comes to early status epilepticus, various studies have come, and out of which all of them have just the same finding that pre-hospital treatment with benzodiazepine is the best. Administering benzodiazepines as a first line therapy is the best. Benzodiazepine is the mainstay of treatment. So that is the outcome of all these studies. Coming to established status epilepticus, there is ESSET trial, concept trial, Eclipse trial. All of these have proven the equal efficacy, equal role of phenytoin, phosphonatoin, levetiracetam, valproic. They're all at the same level. Nothing is inferior or superior to the other. So any of these agents can be used in an established status epilepticus. Coming to refractory status epilepticus, one trial which compared propofol versus barbiturates, found the major finding here was barbiturate was associated with longer mechanical ventilation, which we saw earlier. And one midazolam versus TCI propofol infusion study, they saw that the choice of anesthetic agent does not seem to affect the overall outcome. In super refractory status epilepticus, brexanolone as an adjunctive therapy was studied, and they suggested possible development as an adjunctive therapy, which again in the status trial was disproved. And then finally, the TRENDS trial, which is a treatment of non-convulsive seizures, they saw that lacosamide is as good as phosphonatoin for the treatment of non-convulsive status. And they also provided a guideline for using the continuous EEG monitoring for the status, non-convulsive status. Now, after all the theoretical part, coming to clinical aspect, practically what we see and what we do in treating status epilepticus, I'll just describe a case scenario. A 65-year-old man weighing 80 kgs with no past history of seizures is admitted. He has a GTCS of 5 minutes and is given 2 mg of IV lorazepam. After multiple brief GTCS, he is given a further 2 mg of lorazepam when he becomes obtunded. After a further 10 minutes, when he has developed subtle left facial twitching, 1 gram of phenytoin is infused over 30 minutes. After a further 15 minutes, by the time his GCS has dropped to 8, anesthetist consultation is sought with a view to transfer to the ICU. Now the question is, what would you do differently? What went wrong here? Now, as we saw earlier, what is the protocolized approach for managing the status epilepticus, which is the first line, second line, third line agent? Firstly, they have given only 2 mg of lorazepam. It cannot be stressed how important it is to give the correct dose of benzodiazepine. 4 mg for an 80 kg male patient is definitely required as the initial treatment, after which the phenytoin infusion again It's 20 mg per kg is the dose. Weighing 80 kgs, he should have been given an infusion of 1600 mg. And immediately, 10 minutes after receiving the first dose of lorazepam, if he was still showing signs of seizure activity, further 4 mg has to be given. That is, the second dose of benzodiazepine has to be repeated, along with starting of this phenytoin infusion. And any further seizure activity immediately after that should have prompted immediate referral to the ICU. So time is of essence when treating status epilepticus, because the more duration, and we saw that the more duration the patient seizes, the more this receptor trafficking happens, the more neuroinflammation increases, the more he goes towards refractory, super refractory status. So acting as early as possible is very important. Now let's do a step-by-step breakdown of how an ER physician will act in case of a status epilepticus. The first step whenever a patient seizes is to check the sugars, because hypoglycemia is the most common and the most easily treatable condition when it comes to managing status epilepticus. Immediately check the sugars and start a benzodiazepine. And I have kept repeating this again and again, benzodiazepines are frequently underdosed. That's because of the concern of respiratory depression. But what we have to remember is aborting the seizure probably results in less respiratory depression despite the higher benzodiazepine dose. All right, and then go on to check the ABC. You would wonder why ABC after the first benzodiazepine dose. That's because terminating the seizure activity itself will often solve the airway and breathing issues. Of course, oxygen is can be administered by nasal prongs and all at this level. Blood workup will again start at the initial level itself as the treatment starts. And then, of course, establish a good IV access and more benzodiazepines. All of this happens every 5 minutes. The patient seizes, immediately you have to go on to the next step. More benzodiazepines, treat treatable conditions, metabolite, electrolyte abnormalities, and eclampsia, etc. Then, if the patient still continues to seize, go on to the second level, that is a phenytoin or levetiracetam or valproate or any of the other second line agents. Again, give a good, adequate dosage. Now, the guidelines don't really give you the timeline, as I've told earlier. But clinically, what we have seen, early propofol, an early anesthetic agent, is definitely very, very beneficial, because the asset concept eclipse trials have all shown, they've effectively demonstrated that all of these traditional agents, the second line agents, are equally effective, or in other words, they're equally ineffective. Now, a patient who is continuously seizing for 5 minutes and 10 minutes and not responding to any benzodiazepine is less likely to respond to your phenytoin or any other second line agent. So it is better to skip and then go on to an early propofol therapy. But again, you have to choose your patient. That's very important. If a patient is responding to benzodiazepine and goes into a post-ictal confusion or throwing seizures intermittently, then definitely go in for a infusion of the second line agent. But if he continuously seizes, then definitely skip the second line agent and go in for the third line agent, early propofol. And then, as we remember, there's upregulation of the NMDA and downregulation of the GABA receptor. So maybe even your propofol will not act. So immediately add ketamine. This adjuvant adding of ketamine when you are suspecting that patient has reached a level of refractory status epilepticus plays a very important role, and that will curb the status immediately over there. And this concept has indirectly been also been given in the American Epilepsy Guidelines, Society Guidelines. They state that depending on the etiology or severity of the seizure, patients may go through the phases faster or even skip the second phase and move rapidly to the third phase, especially in sick or ICU patients. So it's basically your clinical judgment, how sick you think the patient is, what can be the etiology, what can be the prognosis of the patient. You have to do it at the bedside and then take a call. After which, of course, following that is placement of an advanced ARA plus or minus paralysis, go in for a alternative therapy, barbiturates. This is, of course, if the patient continues to seize, and of course, the workup, blood workup, and imaging, and all of that. So, finally, the take-home message: it's very important to understand that status epilepticus is a time-sensitive emergency. You have to understand the time-dependent evolution of the neurotransmission in status epilepticus and uh, tailor the treatment around the stage of the status epilepticus. Very important to, again and again, this receptor trafficking and the neuroinflammation which I talked about. So when you're suspecting that the patient has gone into refractory status, immediately understand that no matter how much of the GABA modulators you give, he is not going to respond to that. So go in for a higher agent, go in for ketamine or other higher therapy, and minimize the treatment delays. Go in for a continuous EEG monitoring, and go in for polytherapy and early switching from benzodiazepines to the other anti-epileptic. Don't keep waiting for the responses to occur. And so aggressive therapy is what will help from taking the patient to a refractory to a super refractory, where even sometimes even the other higher non pharmacological modalities may not help. So that polytherapy and this kind of an aggressive approach will help in treatment success and outcomes in the convulsive status epilepticus. Thank you.
Thank you, Deepti. That was quite a comprehensive take on status epilepticus. Um, I think the anesthesia students who are coming up for the exam, they just have to go through these slides, and your whole topic is done. I just want to add a few things. These are very practical. Theoretically, she's done a beautiful job. But when you are on floor treating a status patient, there are few more subtle things. You rightly said the breaking of seizure is of paramount importance, and in that the initial drugs are your benzodiazepines, propofol, etc. The seizure drugs cannot be and or. They have to go simultaneously. So it's a three-prong approach to a status patient, starting right away from ED. You try and break the seizure with benzos. You at the same time load with phenytoin. As rightly said, the dosages are very, very important. And then also take blood work for establishing the etiology. You did mention the etiologies. Very common. Almost 75% of the time, they are reversible causes. Non compliance is very, very high. Underdosing is very, very high. Also, you have to have a proper history to rule out whether there is history of being awake throughout the night, CO2 retention causes, OSCs, and like you said, hypoglycemia. Hyperglycemia is also very common a cause where all your standard drugs which has been prescribed to you and you were used to will start becoming refractory. So diabetic ketoacidosis is a very understated cause, and that has to be treated many times. The seizure will just abort. It will not go on to the next stage. So that done, another very important on table factor is drug interaction. Once the patient steps into the ICU, there are so many drugs that go on along with your treatment of the etiology or primary cause the patient has come to with, which have drug interaction that everybody forgets. So when you start phenytoin, valproate together, when you start levetiracetam with other drugs, you have to have a list of what interacts with what and how to intervene with that, and properly dosing. Continuous EG, you have already said. One factor about thiopentone, sooner you start it, better it is. Like you said, breaking the seizure. It's very simple to think there is an aberrant electric circuit and you have to just disrupt it. Whatever it takes to disrupt, you have to do it. So there is no point of going step by step and waiting for everything. So sooner hyperpentone is started, the better it is. But one factor, when you have become you almost losing the game, if you are reaching the state of brain death with hyopentone, it is very difficult to establish that. So, have you reached the end point with hypentone? You will have to do many, many factors. In fact, we've had one instance where for 7 days the hypentone went on, and patient started having DI. There was no way to establish whether she was brain dead or not. We had to do a nuclear study to make sure that there was no uptake. That's how we declared. So that one point practically is very important. Um, Ketogenic diet, well, the importance of ketogenic diet and any success with that is because any metabolic cause of metabolic, I mean at mitochondrial level, metabolic pathway disruption the diagnosis to be established, especially in pediatric population, takes a long time, and most of the therapy revolves around ketogenic diet. So if you've ever had a good success with ketogenic diet, probably it was a mitochondrial disease, a metabolic system abnormality, which will take time to establish. So ketogenic diet has its own advantages, disadvantages. That is up to neurologists to decide what is of paramount uh, significance in that patient. I have no idea how many of you have used Anaconda. This is the anesthetic system. Instead of, I'm not an anesthetist, by the way. Instead of giving your big machine and scavenging system into the ICU, which space occupies and it is very difficult for us to handle, this is a very small little device which comes into the tubing of the ventilator system and does all sorts of scavenging, everything taken care of. Again, the sooner it is established and the sooner you give inhalational doses, the burst suppression is established much earlier. And only problem with this is you can use this device only for 24 hours. So you have to break the seizures and then you move on to your thiopentone and the rest of the things. The burst suppression will continue, and the chances that there will be success is much higher. The outcome is going to be better. So these were my takes. Any questions, please?
Yes, ma'am. There's one question. What is there any role of hypothermia in treating refractory status epilepticus?
Deepti, you want to answer that?
Yes, hypothermia has been tried for management of status epilepticus, but again, just like any other modality, which is the non-pharmacological modality, we cannot see the patient is already on many other agents, anti-epileptics, all of that. So we cannot really say the success rate is seen. What is seen is because of hypothermia, and it has its own side effects, as we all know. On it has its effects on the cardiac. It can cause arrhythmias. It will cause coagulation abnormalities, and it's not really a very commonly used modality. But yes, it is one of the modality for another one, the alternative therapies for status epilepticus.
So I would just want to add that it is not a standalone therapy, but hyperthermia has to be prevented at all costs. So rather than aiming for a hypothermia, all the measures you undertake for cooling is to attain a euthermia, because hypothermia is very very detrimental. So and as you know, when once a patient starts into seizure, your temperature will go up. So this will be an add-on therapy to prevent hypothermia rather than inducing hypothermia. Inducing hypothermia per se or hypothermic temperatures per se making any difference to the outcome is not well established, definitely.
When do you start de-escalating therapy in cases of status epilepticus?
Deepti
So,
again.
de-escalating therapy, when it comes to the continuous infusions, if you're giving a propofol or thiopentone or ketamine or even isoflurane, so it is not ideal to go beyond 24, 48 hours. Sometimes you do give 72 hours and even beyond that, but ideal would be to give it continuously along with an EEG monitoring for 24 to 48 hours and then reassess. Uh, Try to de escalate and then look for the response. If we are successful in slowly weaning off the patient out of it, earlier the better, because as I said, each of it has its own side effect and further implications. So ideally 48 hours is what we go for, aim for. Yes, we have given for much longer period, as ma'am said. Yes, thiopentone sometimes 3 4 days or 5 days, and then yeah, but best way would to go ahead would be always reassess after 48 hours. Try to de-escalate as early as possible, because even these therapies have their own side effects.
So in our practice, what we do is we do not have continuous EG. If you have the luxury, 24 hours since the burst suppression is achieved, We look for any cessation of tonic-clonic movements 24 hours since then. I also forgot to mention, if you don't have continuous EEG, you have to give more than due respect to tachycardia and tachypnea. Those are the very subtle signs that there might be non-convulsive seizures. We are still a low middle income country. Continuous CEG is far from becoming the norm. So these subtle points have to be given due respect, assuming that they are going to be suggestive of a ongoing seizure process. So any of the patient had tachycardia, tachypnea, you've given drugs and it's ceased, and you're not seeing any non-convulsive convulsive movements, we would continue the therapy for another 24 hours, making sure that everything is all right, and then start tapering.
Any cases where plasmapheresis or IVIG could be in earlier stages in your experience?
Immune mediated etiology, establishing the cause right now in the country, is very, very difficult. What our neurologists do, especially for pediatric, is to send it to Harvard, and the result takes many weeks to come. So in the meantime, in as much as we rely on going on to inhalational anesthetics, we would also try plasma exchange and IVIG. We go rather for plasma exchange than IVIG, simply because it's more economical for us. IVIG, how long to give what dose is not clarified, so there is a lot of ambiguity to it. More easily doable and readily doable is plasma exchange. So yes, we have done, but I can't vouch for success because many therapies were ongoing already. So which worked and which didn't is very difficult to say. But yes, where the neurologist thinks that there is an immune mediated pathology, we have done.
One last question, ma'am. Any role for early tracheostomies? When would you consider doing tracheostomies in these patients?
So by the time it's become refractory and you've started using your second line things, especially you've gone to thio and all, you are going to take a long time for the patient to wake up and start weaning. So once we reach the level of thio, we go for an elective tracheostomy because the chances of VAP is high, and tracheal toileting becomes much more easier with tracheostomy. That is the sole purpose. But per se, there is no definitive indication as such. Keeping the airway after a week or so with so much of sedation is very difficult, because if there is an accidental extubation, that is going to kill the patient for 100%. So, to prevent such things and make our lives probably more easier, we tend to, within a week, tend to go for a tracheostomy.
That was the last question, ma'am. Thank you very much, Deepti ma'am, for the wonderful lucid presentation and a lot of take-home points. And Shalini ma'am for walking us through the ICUs of what we deal with on a daily basis. On behalf of NCSI, I would like to thank both of you for this wonderful session. Thank you very much.
Thank you.
Thank you.